Lancashire and South Cumbria board meeting held in public. First of all, I'd like to start, as I always do, by welcoming those members of the public who are observing this board, either in meeting or on the live stream. I've got a number of other welcomes and goodbyes as well today. So firstly, I'd like to welcome Tracy Hopkins. So board members will recognise Tracy Hopkins from public boards before, but this is her first board meeting as a partner member for the VCSFE. So huge welcome to you. And also Kath Wally to her first board meeting as the second partner member for local authorities. It would have been Denise Parks' last board meeting, but she's had to give her apologies. But I would like to thank Denise for her contributions over the last couple of years. And I'm very delighted to announce that Neil Jack, CEO of Blackpool Council, has been appointed to succeed the role from June. This will also be the last board meeting for Bimpe Kuta Matakenya, who has been with us for the last 6 months as an aspirant non-executive member as part of a programme. It's been lovely having you. We're not losing you quite yet, but thank you very much. And I know that you've enjoyed the process. And finally, this will be the last board meeting for 2 of our non-executive members, Sheena Comiskey and Roy Fisher. Both Sheena and Roy have been with us since the inception of the ICB. And I'd like to take this opportunity to formally thank you for your commitment and leadership. Both of you, in different ways, have demonstrated unwavering support and commitment to this ICB, and I really thank you for that. We will miss you, but we wish you both all the best. I would also like to welcome now, moving to today's board meeting, Yak Patel, Chief Executive Officer from Lancaster District Community and Voluntary Services Solutions, and Nathan Hearn, Associate Director of Strategic Place Delivery, here for the community experience item. And I was introduced to you, but I haven't.
Jenny Riddle.
Jenny Riddle as well. So Nathan, Yak and Jenny are here to talk us through the community experience item, which is the community support offer for the Lancaster district. Really looking forward to hearing from that. Just before we do that, I'll just do the standard items. We've got apologies from Jane Scattergood, Andy Curran, who has recently commenced in post as the acting co-medical director, working alongside Andy Knox, and Steve Spill and Steve Igo, and as I've just said, Denise Park. Margaret Williams is here to represent Jane Scattergood, so thank you very much, Margaret. And that means the meeting is quorate. Final bit from me. As always, I wish to maximise our time for discussion, so if I could encourage executives to keep introductions to a minimum when you come to talk about papers. I know, because we met yesterday, NEMS have diligently read all the papers, and the agenda and timings should allow for a good discussion today. So without further ado, declarations of interest. I haven't been informed of any. Does anybody have any on today's agenda? No, excellent, fine. So without further ado, minutes for approval as an accurate record of the last meeting. That is of the 19th of March. Are we happy with those? Good, and there were currently no actions held on the board action log. And now we come to the community experience story, the community support officer for Lancaster District. Andy, are you going to introduce us?
I certainly can, Chair. It's a great privilege to welcome you 3 to the board this afternoon. Really looking forward to hearing this. We're going to be focusing on the kind of impact of transformation funding in adult social care, which is going to be a really great thing to hear about together.
Okay, good afternoon, everyone. Hope you can hear me. Yeah, so thank you for the opportunity to come and present this programme to colleagues and people sat in the audience. Jenny and I work for an organisation called Lancaster District CVS. We're an organisation that's been operating for over 50 years, an organisation that supports the voluntary community, faith and social enterprise sector and communities across Lancaster District. I've had the joy and privilege of leading that organisation for about 13 years and Jenny over about 5 years. So And so, yeah, between us, we're going to hopefully just talk about the impact of this programme to you all. Just for a little bit of context, I'm here representing a number of VCFSE organisations and our district council and colleagues from the Lancaster District Health and Wellbeing Partnership Board. You can see those organisations on the screen. And just for further context, and I think this is important, actually the whole kind of core design and starting point of this was born out of partnerships with people like Claire Niebieski, who's a population health lead for North Lancashire ICB, Heather Woodhouse, integrated place leader for North Lancashire ICB, and Mark Davis, who was a chief exec for Lancaster City Council, or is this chief exec for Lancaster City Council, and also the senior responsible officer for this programme, and myself as chief exec, and at the time the chair of the Lancaster District Health and Wellbeing Partnership Board. So a real collaboration between the VCFSE and our district and county and health organisations as well. The programme was then adopted and mandated by the Health and Wellbeing Partnership Board. I think that's important to note in terms of accountability and oversight and transparency and partnership working. You can expect the usual organisations on that partnership board in terms of primary care network colleagues, district council, adult social care, and even UHMBT. So yeah, the programme really landed with that partnership. Moving on, so really just for context of the programme, we did receive £140,000 from the adult social care team at Lancashire County Council in order to develop a preventative programme responding to the rising demand of adult social care issues, and by doing so providing them with an alternative programme. It's fair to say that a lot of these adults were presenting with multiple risk factors, but the service that we provided was a safe, proportionate and reliable alternative to adult social care, and actually for practitioners seeking non-statutory support options, so really ensuring that individuals receive timely help that prevents deterioration. Just for context, so I know there's a lot of information on this slide, but it probably demonstrates actually the scale of the issues when it comes to adult social care across Lancashire. But the point for us, really, Lancaster had one of the highest contact rates in adult social care in the county, really driven by people whose needs sat below statutory thresholds, but their problems were real and very complex and escalating. What the data also showed us that actually there was a high level of call volumes, definitely repeating contacts, and a lot of the issues were non-care issues. So you can imagine things like debt and housing, isolation, mental health and well-being. So adult social care sort of felt like they were holding a lot of risk that it wasn't designed to hold. This next slide just kind of gives an indication in terms of some of the issues that adult social care were dealing with. Not to go into that in too much detail, you can see that from the screen. But what I wanted to say is that actually there's a clear link between poverty and health inequalities. So the key wards that actually were presenting the most calls to ASC came from the most deprived neighbourhoods in Lancaster District, and that's Heysham, Poulton, Westgate, Skirton. And then we had one from Bear as well, which is more of an ageing population. So for colleagues who know Lancaster District, I think you'll know those them wards pretty well, but to demonstrate a clear link between health inequalities and poverty and a number of calls that were being received at adult social care.
Yeah, so when we were designing the AIM, we spent a lot of time building relationships with the adult social care teams. So I and my colleagues in the other organisation visited the teams down in County Hall and over in Accrington, and they came to us as well. And we spent a bit of time understanding how each other's works. It was really, really important to get that real good understanding about how the beast of adult social care worked and how we worked as a sector as well. And then we were able to come up with this aim to help maintain independence, improve well-being and remain connected for people. Next slide. So the operational objectives were, as you can see on the screen really, preventing escalation through early proactive intervention, supporting independence and well-being, through strengths-based person-centred support, providing a consistent referral pathway from adult social care into trusted VCFSE organisations, and improving access to advice, practical assistance, volunteering support and social connection, and basically reducing the pressure on adult social care staff by offering safe, appropriate alternatives to statutory work.
So in terms of how the funding was used, we came up with the sort of following system interventions to be able to hit those kind of needs. I mean, it's fair to say that actually the system wasn't sustainable for residents or for partners at ASC. Now, we could have run a traditional grants programme and just distributed the whole funding to the VCFSE sector, but we felt that wouldn't have really sort of fixed the problem that ASC were facing. What we recognised, if you go back to that table of, in terms of need, we knew there was organisations in our sector that actually could start to meet those kind of demands. We knew there was expertise. We knew we had strong relationships, so it was important for us to kind of really hit the ground running. So we invested £60,000 of that into an organisation called Positive Futures, who is our main mental health charity in Lancaster District. Citizen Advice, who I think a lot of people know what they do, but in terms of financial and housing support, and then Bay Volunteers in terms of sort of befriending and reaching out to lonely, isolated people in our communities. We let that run for a number of months, and then we decided to launch a competitive small grants programme to those key neighbourhoods that we mentioned early on in our slides. What we recognised was in that most disadvantaged communities in Lancaster, there's some areas that lack social infrastructure. You know, there's some that have strong, but there was a key neighbourhoods that didn't have social infrastructure. So it was really important that we invested £21,000 into activities that could go into those neighbourhoods and start to work with residents that needed support. And then we ran a communications campaign. We paid Royal Mail a good part of £10,000 to deliver these postcards. We can send these around, and roughly to 10,000 households across those key neighbourhoods. What this enabled, we've got a digital directory in Lancaster. We wanted to signpost people to services and activities. There's a QR code, website, and that resulted in one of the biggest sort of website hits in our history, actually. So this was a really effective way of actually doing some prevention and self-discovery of activities that their families and people could find. So we'll be happy to sort of share that. And then finally, we invested £20,000 into some back office because we felt that we would be to be high demand for our service. Actually, we didn't use that funding, and we was able to reinvest that back into the programme. So in terms of achievements and benefits, I mean, you can read that on the slide yourself, but really we felt like there was a significant left shift in the system for adult social care and for our communities. On an individual level, the usual things in terms of reducing isolation, we stabilised people's finances, we improved people's confidence and well-being. On a system level, we had 80 avoided ASC contacts, roughly about £170,000 in avoided costs, and we reduced assessment demand and improved practitioner confidence. I think this is what less shift looks like. In practice, there's lower cost, earlier relational support replacing later statutory intervention. In terms of sort of neighbourhood working, and going back to that earlier slide about some of our most disadvantaged communities, we put investment and focused in those key neighbourhoods. Community organisations were embedded, and we responded very, very quickly to the demand and the issues in those communities as well. I think neighbourhood-based delivery meant support was accessible, it was trusted, and it was realistic for people's daily lives. But I think the bigger story is quality, safer decisions, earlier help, and fewer people accessing or escalating into assessment crisis and safeguarding. And again, I don't want to go through everything, but you can sort of see in terms of the breakdown, in terms of what we did, you know, there's a lot around mental health, around housing, around care-related pressures. But you can see sort of the highest engagement, and I think this is what we're proud of. So those key areas of deprivation, they were the highest engagement of this programme. So we're proud of that. But then you sort of look at the lower engagement, and again, the people who understand Lancaster District, Boltley Sands, Silverdale, LL, we had people coming from those neighbourhoods, which demonstrates, I think, more the older population, more isolated population, but they still were able to access this service and understand that this was available without very much marketing. So, yeah.
Yeah, so this was really important for us, the networking with the teams, the adult social care teams. What changed wasn't just outcomes for residents, it was confidence across the teams from both sides. So all the way through, we were able to communicate with all of the teams in adult social care we worked closely with to make sure that we were doing they were giving us appropriate referrals, and that we were giving them good feedback and closing the loop at every possible moment. Social workers knew that referrals would be accepted and feedback would come back and risk be held proportionally. And that changed the day-to-day culture, and it really helped with getting the culture right for the project in general. We mostly worked with the Wellbeing Early Support Service, the Community Assessment Team, and the Specialist Support Team. And they're all very, very different in adult social care, but they all have really benefited from our work, and vice versa as well.
And we deliberately included practitioner feedback here because I think it speaks about trust. I think the partnership reduced waiting times, it removed duplication, and let social workers focus on statutory work and not dealing or deciding on community options. And the last couple of slides you'll be pleased to hear. But again, we wanted to kind of demonstrate the potential savings to adult social care. I think we've been careful and conservative in estimating savings. Based on hours of support delivered and avoided contacts, I think the value release sits somewhere between £86,000 to £277,000, and that's before you even sort of touch care packages, costs. For relatively modest investment, we believe this is a strong return, but more importantly, it prevents human and as well as financial costs. And sort of looking at the sort of public information, if you sort of, you know, it's roughly about £360 for a GP call cost and roughly about £1,600 for multiple visit costs. You can sort of demonstrate how much we saved the system in terms of doing this programme. And we believe this is replicable. And I think just to sort of point out key things, we've created a clear referral criteria. We created an end-to-end solution for practitioners and social workers, and in terms of communication. We built trust. We co-designed it. We took a population health approach with this. And more importantly, we've got really strong connections to our neighbourhoods. So I just want to finish off by saying, like, we think this worked because it tackles the real reasons that people turn to social services. They're experiencing financial difficulties, housing problems, isolation, mobility challenges, or the stress of caring, and they don't know where to go for help. This worked due to one front door referral pathway, understanding each other and co-designing every aspect of this pathway. We had a culture of respect, we had a culture of kindness, and a culture of love that we developed between us. We believe that this worked because people were receiving contact within 48 hours of receiving the referral, and this worked because we accepted every referral that came in. We prevented repeated ASC contact by providing ongoing intensive support, and we prevented crisis in people's lives or lifting them out of the difficult situations. And we kept people away from emergency interventions and statutory services. So I hope that's been a useful presentation and information, and we'll be happy to take any questions. Thanks for listening.
Thank you. Do you want to say anything? No?
Yeah, I'll come straight in, Chair. Thank you. Yak and Jenny, thanks for such a powerful and brilliant presentation. It's so lovely and heartwarming to have a story like this at the start of boards. A few things I just want to draw out and emphasise. Firstly, I love that Yak talked about the population health approach that they've taken here, and it's very similar to our targeted demand management approach that we've been taking in other communities, but this time showing that approach doesn't just work with health issues, it really works across social care as well. So some really good spread learning for us together. I want to emphasise the high quality of leadership. Yak's an outstanding leader. I've had the opportunity of working with him over the last 12 years, and this guy lives his values as well as, you know, and how he leads his organisation as well. And the quality of leadership I think that we've got in North Lancashire and around Morecambe Bay is just exquisite, both within the voluntary community faith sector, but kind of in the interplay and the relationships that have been built in working in this way over quite some time. And that's not easily won. It takes time to really develop those relationships of trust and do things together through things like the Poverty Truth Commission and Art of Hosting and a whole load of working with communities in this way. But I think what this does is it shows the impact and the agility and flexibility of our VCFSE partners who really know our communities and can be really trusted with good pots of money to work well in this way. It demonstrates the strength of high-functioning health and wellbeing partnerships. So as kind of subsidiaries of our health and wellbeing boards, when health and wellbeing partnerships work really well and they've taken time to build relationships together, the things they can achieve when you've got that real cross-sector leadership in a very integrated way in place. It's a fantastic model for how you then distribute finances differently in a high-trust environment that makes a real impact. I think it enables all partners to then work more effectively. What we've seen is it's enabled the VCFSE to lead in work that they can do most effectively, but it's also released our adult social care and health teams to then do their jobs more effectively as well. And it's then created benefits all round, both in terms of finances, but better outcomes for our communities. So for me, I just want to not only applaud this work, but say, can we learn and spread and we don't want to keep having isolated stories at board. We want to see the joined up impact spread across lots of different regions. But just massive credit to Yak and the team. And thanks for coming today, because it's a very wonderful story and brings real hope to us, I think, at a time of significant change and challenge.
Thank you, Andy. Aaron.
Yeah, thank you. So thanks, Jenny and Yak. So I was going to reflect on the first part of Andy's feedback. I had the pleasure of going out to Blackpool on Friday, meeting with a very similar group of colleagues working in Blackpool with targeted demand management. And I just think there's a couple of comments I would make. So I think we set the bar incredibly high to prove concept and return on investment when we talk about scale of investment like this for the VCSFE sector. And I'm just holding the mirror up to us as an organisation. Do we apply the same rigour and expectation in all parts of the market to demonstrate value in this way? And I would challenge us to see if we'd see the same response in all parts of where we invest our resources. That's something I'm curious about, Chair, to think about in the next phase of how we report, how we track measures of success and where we deploy our resource. The other point I would make is this now sustainable? Is this a model that's now in place and will continue to deliver?
So we didn't receive the same level of funding for year two. It was a part of a transformation funding in year one. We secured £15,000 from ASC, the Adult Social Care Team, and then we put a further £20,000 of our own funding to top that up. So it resulted in much lesser referrals and less complex cases as well. So
again, Chair, on the first point I've made, something that demonstrated potentially up to a 2.5 times return, we reduced investment by 80% for the second year. It's counterintuitive, and I think we've got something really wrong in the way we allocate resource, we promote improvement. Apologies, Chair, I'm on a bit of a thing here. but it's important because as we move into a new way of working, these need to be less of nuggets of really good stuff. And to Andy, I know why you make the point, but the question of can we learn and spread, that's ours to answer. Yeah. So we are the convener, we're the market manager, we're the commissioner. So we shouldn't be looking at small teams to say, can you now go out and go and spread it to Preston because that's the next one. We have a responsibility to do that. And I'm in quite a space at the moment, colleagues, just around the reset and what we do next. And this is my 6th board. And we keep hearing small nuggets of really good stuff at community and place level. And I was tracking back through my board minutes. The first question or second question is always, is it sustainable and can we spread it? At some point, we're going to have to answer those questions ourselves. Yeah. So, fabulous story. Apologies on our behalf that it doesn't feel like we're getting it quite right in the promotion, the sharing, the spreading and the investment. That will change. Thank you.
Thank you, Aaron. I've got Chris, and I've got lots. Kath, and then Julie.
Perfect, thanks, Chair. And it was just on one of the slides where it taught, I think it showed mental health of contacts to statutory was about half, if not lower than half of contacts. And yet through the referrals, it was 45% of the referrals were for mental health. So I think there's something about tapping into that unmet need of citizens that aren't reaching statutory, but this is actually stopping people potentially before they get to that crisis point. And I think so. And that's hard to quantify when they're not accessing service currently. So I think it's another bit to what Aaron said. It's another positive that's come out of this. So yeah, no, just to bring that out.
Thank you. Thanks, Chris. Kath.
I've got the choice of microphones. Thank you, Chair. Yeah, honestly, I wanted to clap at the end of that because I did. I just found it so inspiring. And I'm here to represent local authorities, but this is something we're grappling at the moment in the local authority where I'm a director of adults. I think there's massive opportunities here, isn't there, in terms of thinking about that. How do we do this together, jointly? Because the benefits of this just shout from the rooftops, don't they? And what we want to do is prevent people entering the system, entering hospital, entering healthcare or adult social care prematurely. So I will be speaking to you outside of here. I think I might even be in the same place as you on Monday afternoon, so we'll speak more then. But yeah, absolutely, I'm 100% behind this, and I know I can speak on behalf of my local authority colleagues when I say that. We're all grappling with really challenging budgets and things like that, and actually, when the budgets are challenging and your back's against the wall, that's when you can be your most creative, and I honestly see this as being the most creative way forward. But it can't be done with little bits of piecemeal. Here's something for 12 months and then it falls away. It needs to be something sustainable that we grow, and then actually we start to see a shift in what the current workforce starts to look like because different ways of working come forward. So honestly, brilliant, and I look forward to seeing you on Monday. Great job.
Thanks, Kath. Julie.
Thank you so much. It's great. There were two things I picked up on that you said, and I think they're really crucial for like patient experience, was how you said the one front door and nobody gets rejected. Because from often when we try to do these things, we can get it wrong because patients end up, though they experience, they get access to lots of things, they have to tell their story 5 times. And that becomes very wearing. And so it's so lovely to hear that the organisation that you've managed to put in place, that means that the patient experience is going to be so much better.
Thank you. Yeah,
thanks for that.
no, thank you. Tracy.
Thanks, Chair. Yes, I mean, listening to what Aaron said is like music to my ears. I mean, I always love these sections of the public board, but I always think that we compartmentalise this and we listen to this and then we go into our business and sometimes maybe forget about what we're hearing here. So I'm really glad to hear Aaron talk about sustainability. All the points that Andy made, absolutely agree with, and it's an absolute pleasure to have Yak here, a colleague on the VCFSE Alliance as well. But the one point that I don't think has been teased out quite as much as I'd like it to be is the work that's happened with Lancaster CVS has stepped us again into that space of the VCFS sector acting as a convener of quality services in our community. So it's very similar to the capacity investment funding that came through the Alliance. And it's where the sector are trusted to be able to take an investment, work across a partnership and deliver quality. And I think we sometimes underestimate the power of that and the fact that we have some very high quality delivery partners with some of the most regulated, scrutinised and organisations within this partnership. I mean, I can talk with authority about citizens' advice, and I think often we forget that actually what we're talking about is people getting that integrated service which is of a really high quality. And I also know that Jack has been incredibly modest about this return, because he's not even talked about the benefit gains or the lifting people out of poverty. You talked about poverty, Jack, that is achieved through a programme like this. The long-lasting effects, the impact this has on individuals and families, we've not even scratched the surface. So I think it's not like you, Jack, but you've been very modest today. I think I can say that as a friend and a colleague. So I'd like us to really seriously think about what Aaron has said around how we stop tinkering around the edges with this and make this more about our business as usual. Thank you.
Thank you, Tracy. So I'm going to follow up on those by saying, so what? So what are we? What are we going to do?
Thanks, Chair. So as part of my brief, there'll be quite a bit on our restructure, resetting the organisation. In September, when we've completed that, there'll be a series of sessions with board and our senior leadership team about what does it mean to be a strategic commissioner? How do we get serious about long-term population health improvement and measure our impact on health inequalities? Because whilst they are statutory functions of an ICB, we don't spend a lot of time at the moment focusing on those, talking about them or reporting on them. So come the autumn, I will want to convene lots of conversations in the summer with partners, including VCSFE. How do we get this better? How do we respond to the challenge of longer term investment, trust and confidence, measures of success that we then prioritise as a board and as a leadership team to start to move into what I think is really needed at place level? So there's a commitment from me as the chief executive, I know you share that, Chair, that we will build our models from the reset to get this right at the heart of the work that we do. I'm fortunate, Chair, that I spent 12 years also in Morecambe Bay, so I can see really clearly how this benefits. My eyes been open in visits to Skelmersdale, into Burnley, into Blackpool, into Blackburn. This is happening in lots of places, so we have so many examples of this kind of work. It is not beyond the wit of us all to make that part of our core operating model, and that's the commitment.
Thank you. I think we would all very much welcome that. And I also think it's important to say that the September sounds like a long way away, but in fact, given the agenda that we're currently dealing with, that is actually quite a short timescale. But yeah, really welcome that. Thank you so much for coming, for prompting this discussion. And you're more than welcome to stay, but you might have other things that you want to go and do. Thanks very much. Thank you. Thanks very much indeed.
Thank you.
Okay, so my report is reasonably as read. I mean, the only thing I would say is today's agenda gives us plenty of time for discussion. I think there are three, the usual committee and performance escalatory reports, but three key areas: the finance report, which talks about our last year's financial year's achievement, which shouldn't go unnoticed. The board assurance framework, which helps us to look towards next year, which is in fact this year now, and the board is thinking about how we develop that, how we make sure that it really starts to focus our thinking on what our strategic objectives are, what the risks are, and how we mitigate those risks. And then there is a case for change in the case of secondary care orthodontics. So just to sort of orientate people a little bit. But very happy to take any questions, but it's a fairly straightforward report this month. Okay, so I think we'll now move to you, Aaron.
Yeah, thank you, Chair. Obviously, my report contains all of the work that we've been doing as an exec team and some of the national programmes that have developed since we last met. So I won't go through it in detail, I'll just pull out some key themes. I'm going to start with a thank you and a recognition for colleagues working in our organisation and the system at the moment. So the Chair's just referenced the finance report, which Mark will talk to, but it's clear that across the system, all partners worked incredibly hard to do two things: to try and get to a position where our financial sustainability was starting to improve, and you can see we've managed to do that together over the last 12 months, at the same time as improving access, quality, and some of the service improvement work that we wanted to progress. And I know there was lots of nervousness at the start of the year around, can you do those two things, and are we putting risks in the system? Not easy, and I know we would want to have gone further, particularly on the quality and service improvement, but you can see evidentially we've managed to do that as a system, and it should give colleagues confidence that even under real challenge and what can at times feel like impossible asks, teams coming together, focusing on the right thing really well helps. So just a thank you to everyone that was involved in the last year. All bar the shouting, we've achieved most of our year-end targets, which again is a fantastic achievement. I also want to recognise that the organisation is going through a significant change. So every colleague that's currently working on these things that we rightly celebrate and talk about and wanting to improve, all of our near 800 colleagues at the start of this year are going through a process that means their future is uncertain, the structures are uncertain, and what we're wanting to do together is ever more challenging. So it's in that context, Chair. I won't say it in every agenda item, but whenever we're talking about key pieces of work, there are colleagues working on this and committing to this whilst really quite fearful about the future. I'm very, very proud of the work that the leadership team and the exec team are doing on helping progress that and support colleagues and be really clear and try and get to decisions as quickly as we can. And we expect to do that over the course of the late spring, early summer, which is why September, Chair, becomes such an important time, because it should be the time when we can sit with some stability and talk with partners about the future models that we want to improve. There's a couple of other things in my report just to pull out. So we have our couple of areas of service change and improvement. So I'm going to mention SEND. And the work that's happening now across the system. So there is a national requirement for local authorities and ICBs to come together to talk about SEND reform, to really commit to moving away from reactionary, quite difficult in terms of those that need the service to access the service, and long waits and gaps in service that are creating real problems. You will know that the Lancashire and South Cumbria inspection report for SEND wasn't entirely positive. They're two separate things. There's an action plan, Chair, to improve in that area, but the reform work that we're putting together now will help address the underlying causes. Really pleased that this is being done in conjunction with all of our local authority colleagues, and our teams are playing their full part in how do we commission better, how do we help providers in the market close the gaps that they have, how do we work with families and the users of service to really listen to what's important to them so we don't miss that when we put our plans together. Plans will go in June, Chair, and as they develop we'll be bringing periodically updates through quality, well, it'll actually be our commissioning committee and board with progress. I wanted to mention SEND in particular. We've also got the release of the neighbourhood working guidance from the centre. We have two neighbourhood pathfinders in Morecambe Bay and Blackburn with Darwin, so we are fully engaged in taking that policy forward. I mentioned the targeted demand management in Blackpool. We've just heard from Yak and Jenny about a piece of work. That's what we mean when we talk about neighbourhood working, integrated partnerships. It's not just a policy, it's not a contract framework. This is about how we deploy resource, trust and confidence and convene partners at place. So really pleased that we're ahead of the curve, I think, on the neighbourhood policy. The challenge then is we have other places that aren't in the Pathfinder, and we want to make sure we're connecting, learning and sharing the resources that are coming to support that more widely, which we will absolutely do. And then you mentioned briefly, Chair, service change, case for change. Appended to my report is a list of service changes that are being proposed for the next 12 months, just to give a sense to colleagues as to what's coming and when for decision making and the kind of priorities we've seen from providers in the market as to some support for change. This is a discipline that will continue as we work through the rest of our 3-year planning cycle. So periodically we'll bring into board service change roadmaps, for want of a better phrase, so it's really clear as to what we're trying to achieve. One of the things we'll do in the autumn, we'll have our clinical strategy coming to board in July, And then in that September reset, we can have a bit more of what I call the picture on the jigsaw puzzle box, so we know what we're trying to work towards. And every time we're making a decision, it's clear what we're trying to build in the future. That will really help, I think, both colleagues in the system and our board kind of work through that. So that's as much as I was going to say, Chair, on my report, but just a reflection of some positive progress to this point. But having just had the dialogue we've had, still more to do to develop and change and improve from this point on.
Thank you. Thank you very much, Aaron. Any questions for Aaron or his report? No. Yes.
Yeah, Chair, just briefly a comment really, which is fantastic reports and really good to be part of the work that's going on. But I think I'm provoked after our presentation from Yak and Jenny and how it relays into the SEND work as well. What's the learning that we can immediately take forward into that? Because if we can do it with adult social care, we should be able to do it in SEND as well. And so I think there's some really good learning for us to have a conversation with our local authority colleagues about the vital role that the VCFSE could play with us in really transforming the SEND agenda across Lancashire and South Cumbria.
Yeah, no, thank you very much. Good. Okay. And just before we move on, I think I would just like to, on behalf of the board, acknowledge that this is a difficult time for staff across the ICB, and we do understand that, and we do appreciate and thank people for the amount of effort that is going in at what is a very difficult time, coming at the end of a very long period of uncertainty. Thank you. Okay, so we're now going to move to People and Culture Committee. Jane.
Thank you, Chair. This is actually the last AAA report from the People and Culture Committee, because this committee is being laid down and its functions taken forward together with that of the Transition Committee into a new committee, which is later on the agenda. And one of the main reasons for that, as you can see from the report, is that the ICB's role with regard to system workforce matters has changed in terms of the recent organisational changes in the NHS. So we no longer have that system role overseeing workforce matters, including education and training. So that's a kind of major change for us. The area that we've alerted to the board, we've alerted it as a kind of potential for a missed opportunity more than a particular risk, is around research and innovation. Research and innovation was included within the terms of reference of this committee. And we received a report from the Research and Innovation Forum on the fantastic work that's going on. But with the changes, there's a risk that this aspect of the work is not seen as core to the ongoing strategic function of the ICB, and that would be a mistake. It's vitally important to enabling us to delivering our strategy and improving outcomes for our population. So we wanted to kind of alert that so it doesn't get lost, and also to ask the board, whether through a development session or some other means, to just give that some more thought in terms of how we make sure that we carry forward research and innovation in the ICB going forward. The other area to mention, I think, and it relates to what Aaron and Emma were both saying, is this committee has had oversight of wellbeing and staff experience, and this will be something that we take forward into the new committee. And clearly, I think morale is low, and there are problems with in terms of how staff are feeling at the moment. Not surprising, given the amount of change that they're experiencing and work on top of kind of busy workload pressures. That said, we were assured in the committee of all the different interventions that are in place and all the mitigations that particularly the OD team are putting in place to try and help staff through this change. And that's something we'll just keep under review and keep monitoring. The committee has a specific deep dive into relatively high absence levels in the nursing indirectorate and specifically within the all-age continuing care team. And we felt through this meeting we had a better insight into that. And also, we now had confidence of the interventions that were being put in place and how that situation will improve, and that's something that board members will be familiar with previously. And finally, I just wanted to mention freedom to speak up. So we received the quarterly Freedom to Speak Up report, and there's uncertainty about how freedom to speak up gets carried forward at the moment, because firstly, the National Guardian's Office has actually been laid down, and that's now being incorporated into the government department. But the other query remains around primary care, I think. We had an instruction without clarification previously that primary care was meant to be included within our responsibilities, and now that's not so clear. But I think that needs further work and development and understanding, because it remains a really important route for colleagues and patients actually in primary care to flag up concerns that they might not be able to take forward in other ways. So those were the main, that's the main feedback from the committee, but very happy to take questions.
Thank you, Jane. I know your question on research and innovation will be music to Aaron's ears, so I'll let him come in on that one.
Yeah, it's a really good point, Jane. So I'm pleased that was part of the conversation at the committee. So I would share the concern that I think it's conspicuous by its absence, because whilst it doesn't feature in our blueprint anymore, it doesn't feature strongly anywhere. So it feels like it's a gap. So I've just started a conversation with the Provider Collaborative and also Health Innovation Network, just to start to convene partners coming together, because whilst we might not have responsibility for that particular strategy, I think we've got a role as a system convener and as a discerning customer as to what we think population health improvement, health inequalities reduction might need from the market to be successful, which leads you into innovation, digitisation and research. So I think my mum would have said, same dog, only washed. We can get into a position where we can influence, convene and push into the space to get it into a better place. And Alex Heritage, who's our incoming Chief Strategy and Planning Officer, will have this as part of his early discussions with system partners to see if we can convene something. I know the Provider Collaborative are really keen to explore this as an opportunity also.
And I will take on board your suggestion of a board development session. I think we'll need to think about timing, but I think that would be a very, very sensible thing to do. Tracy.
Yeah, just on that, again, really pleased to hear it will be part of a board development session, and glad, Jane, that you raised it as an alert, because I think, to echo the point about it, it could drift and get lost. As I read through the board papers, I also looked at the BAF and looked at our work recently around risk appetite. And within the embedded paper, it stated really clearly that innovation is needed to meet demands on services and allocate limited resources. So if nowhere else, then we've already started to embed it within the BAF. So if it can be picked up in that way through a board development session, and us actually look at how we gain insurance around this being met, that could be a route into making sure it's not lost.
Thank you. Thank you very much. Margaret.
Thank you for raising around all age continuing our healthcare and the sickness, but the interventions, just to assure you, really are making a difference around that sickness management. And even over the last couple of weeks, there's a much improved picture, and none of the teams are in business continuity now. So it's really has improved, and the interventions are good. Thank you.
That really is very good news. Thank you. Thank you for giving us that news. Thank you. Andy.
Thanks, Chair. And great report. Thanks very much, Jane. Just wanted to come back on the freedom to speak up issue in primary care. It's really important, and we will be maintaining overall quality impact oversight of primary care as an ICB. And we had a very positive meeting, Aaron and I, with the GP Confederation last week, who are a conglomerate now of the GP federations that exist together. And we had a really positive discussion with them as a provider voice across the whole of primary care about this exact issue and quality improvement and variation in primary care. And we feel really assured, actually, that in our growing relationship with them, that this is an area where we'll be able to keep a close eye on freedom to speak up and quality improvement issues, and be able to develop a much more robust process for monitoring this kind of thing. So, yeah.
I'm delighted to hear that because I share Jane's concern about it. I think it's incredibly important that independent, particularly given the number of practices and its different issues they face. So that's really good. I'd like to note, I'd like that will come through the People Committee, won't the OD Committee, will it? Or maybe the Quality Committee. I'd just like to take offline how we'll get assurance about how that works because I think it is really important. Yeah, Quality Committee. Great, thank you. Good, excellent. Right, so let's move on to the quarterly report of the Board Assurance Framework. Deb.
Thank you, Chair. So this paper provides, it's almost in 3 sections. It provides a summary of the outputs from a board risk workshop that was held in mid-April, and how these will inform a refresh of our strategic objectives, updated risk appetite and the 26-27 BAF. It also then includes an update on our Q4 Board Assurance Framework, including progress on the principal risks and assurances, and it highlights our operational risk register for those risks that score 20 or above. So at the risk management workshop on the 16th of April, the board considered our risk appetite, our current risk environment and our strategic objectives. 3 key strategic risk themes came out of that session, which were around transition and workforce, financial sustainability and strategic commissioning. So these 3 themes and some of the broader outputs from that session will shape the refresh of our BAF and our strategic objectives over the coming weeks, where we will reconfirm our risk appetite and reshape the BAF, which will include merging 2 current risks on the BAF that relate to transition and sustainable workforce into 1 risk, resetting the financial sustainability risk to reflect our position going into 26-27, and aligning ownership and oversight of the BAF to the new operating model and our revised governance arrangements, mindful that we've now got our commissioning committee, and as Jane's made reference, we're making changes to our transition committee and current people committee. All of that work, all of the outputs from that session will be overseen by the executives, and there will be clear translation and reporting into committees over Q1 of all of those outputs as they translate into our current BAF. So the Board Assurance Framework overall position in terms of Q4 reporting, the BAF continues to be well embedded and effective, with ownership through our executive and oversight through the Board's assuring committees. This is supported with strong internal audit assurance, with MIA's Phase 2 review confirming that all our standards are being met and with no outstanding recommendations in terms of our board assurance and risk management arrangements, and that's outlined in a bit more detail in section 5. There's been good progress over Q4, with a number of risks improving or reaching target risk scores. They're summarised in section 3 of the report, where there's a summary of key activity, and drawing out one example, BAF 05, developing and maintaining effective partnerships and collaboration. So over the last quarter, we've seen regular engagement with MPs. There's been engagement sessions with place-based partnerships on the target operating model. Local partners were integral to the development of our 5-year strategic commissioning plan, and we've revised our board membership to further strengthen that sectorial expertise and enhancing board decision making. So you'll see a recommendation on that one to reduce that risk score. And noting as well that given the work from the session in April, that there might be further changes to current risk scores as we see the next presentation back to the board. In terms of operational risks, as I'd mentioned, there are 4 operational risks that score 20 or above. They're outlined in section 5 of the report. and oversight is obviously maintained through the executive and through the relevant assuring committees. So in summary, the BAF's visible and assurance arrangements are robust. We've had good progress made over Q4. Key strategic risks remain, particularly around transition, workforce, financial sustainability and strategic commissioning. And there'll be that significant refresh of the board assurance framework is now underway, and we'll see that all translating through over Q1.
Great.
Thank you.
Thank you. Thank you very much, Deb. That's a comprehensive assessment. We're asked to review and approve a number of recommendations in the report, but before we do that, are there any comments or questions? So I'm conscious that this is, as Deb said, this is backwards looking, still slightly. Oh, it's forwards looking, but hasn't reflected the changes that we've thought through. But it is nonetheless quite important. So Tracy.
I wanted to raise this, and it seems appropriate to do it under this because ultimately, if we don't manage this risk, and you've talked, Deb, a lot, quite rightly, about workforce finance risks, but ultimately this is about ensuring that we don't build inequalities into the work that we do and improving health and care for people across Lancashire and South Cumbria. Board might be aware of a recent ONS report about healthy life expectancy. I think it was about 3 weeks ago that it was released. And it brings into really sharp focus the fact that we've got some huge disparities across our population. We've got some people in Lancashire and South Cumbria who can only expect to live in good health for 51 years. So their health starts to deteriorate after 51 years of age. And I think whilst this seems like a dry document about risk and about our assurance around managing this risk, the ultimate consequences is those things are not going to improve unless we get this right. So I just really wanted to raise that and say that certainly when I come into this space, I'm very mindful of the fact that the gap is widening for many people. And I think Yak said it really, really clearly. A lot of this is very much linked to poverty across our communities. So I think we've got a real obligation to those communities to really understand how we're managing risk and how we're making sure that all the time throughout this risk management process, we think about health inequalities as a thread.
Thank you. Thank you, Tracy. Aaron.
Yeah, thank you, Tracy. We haven't captured it as articulately as we might, but that strategic commissioning, strategic risk, I think has that at its core, which is our desire to move away from larger fixed contracts and annual contracting as a measure of what we're doing, and more about outcomes-based, longer-term relationships, health inequalities reduction. So I think that's what we mean when we talk about the risk of strategic commissioning, because it's going to require really different ways of reporting, really different ways of allocating resources, really different leadership and capability development in our teams. So I think we could probably flesh that out a little bit more. So what do we mean? Why is that such a strategic risk? And it is because the expectations are so different, because what we've had in the last 5, 10, 15 years is an approach that's actually not having any impact at all when you look at those national reports. So that's a great call to arms, isn't it, for us all to say, well, let's do something really different in this next phase then, which might explain some of the response to the presentation we heard, because it's live and it's like, right, well, in that case then this has to be really different. So we'll think carefully about how we construct the risk and the mitigation around that, because it should help shape the strategic commissioning development as we take it on.
Thank you. Julie.
Chair, thank you. It's an observation that I was looking at one of the risks particularly that applies to primary care, and it's a reflection of the freedom to speak up conversation as well, because we have a risk, it says, ability of the ICB to effectively identify and respond to quality and safety concerns for primary care, which is clearly close to my heart, and I feel it's really important. And I suppose it's just a question of, are we as a board, have we set the when, where, how, who plan in order to reach a solution to that by the December as per the risk? So I'm not clear, what have we got that trajectory in mind?
Yes, we do. So I had a really great meeting with our primary care team about 2.5 weeks ago. Would that have been a weekend? I don't know. 2 weeks, two and a half weeks ago, in which we were discussing what we do about quality improvement across primary care and proactive visits, given concerns that have been raised through freedom to speak up and other things that have been muted towards us. And as a result, the primary care team have scheduled over the next, so we have to visit every practice every 3 years. And we have been able to colour code them according to which are our most at risk, are ones of less concern, and are ones that are performing very highly and doing well at the moment. And so we now have a programme of work which over the next 3 years will mean that we visit every single practice, but we will prioritise those where there have been concerns raised or we have quality or variation issues which we can't explain. And the team are already starting those visits. We've been able to garner some really good focused clinical support. So we've been able to change some of the portfolio working of our kind of clinical leads across the ICB at the moment whilst we go through organisational change to make sure that we can give focus where it needs to be. And our primary care team, even despite all the other pressures that they're under, are on with this work, and we're proactively reaching out and working, in a really kind, improvement-focused approach. We're not going in with a stick or to beat people up or to be unkind. We go in with a real sense of curiosity and kindness and compassion, and are taking an improvement science approach to the issues that we find. But just a huge commendation to our primary care team, actually, for the way that they have already responded to some of the risks that we're seeing and how we're proactively intervening in that space.
It's really encouraging. Great question, great answer. Thank you very much. Margaret.
Just to complement what Andy's saying, we've got great matrix working as well across the ICB teams. So any issue arises immediately, safeguarding the other teams, the specialist knowledge and expertise, we're all wrapping round, aren't we, to really work on this. And we obviously get into the more proactive space. Thank you.
Excellent. Thank you. Kath.
To some of what you were just saying there, Margaret. So I'm just looking at the sustainable workforce, and we're all competing, aren't we? We've all having to make difficult decisions around workforce and resources, and I think there are some concerns that are emerging across the local authorities in response to some of the proposals around the new operating model. And I think all chief executives are, we are as councils going to respond formally to that through the formal consultation process. But just what you were saying there, Margaret, around safeguarding and some of the changes that will happen there. So in terms of that specialist advisory service that exists there at the moment, which I think GPs, etc., can access, and I think it's, so where will that now be picked up? And the documentation seems to refer that they'll now have to come through local authority routes, but local authority routes haven't got any increase in the capacity to be able to respond to that. So I just think it's whatever decisions that we're making, we need to be careful and make sure that we're consulting with each other so there isn't an unintended consequence. And I think that the chairs of the safeguarding boards are going to be writing together in response to some of those proposals.
Thank you. I mean, you're right. We do need to just keep talking to each other, and conversations. I mean, I appreciate letters, but actually conversations are how we sort these things, aren't they? Excellent. And I think that was a good conversation that we and I'd like to, in risk management and board assurance frameworks generally, first of all, you've got to get the right structure, which I think we have. We've had some very good feedback from our internal auditors around that. When it's really working, when we're a mature risk organisation, we use this in our day-to-day conversations and our board conversations, and I'm starting to get a sense of that in some of the conversations today. But this will come to the board 3 times a year?
Yes.
3 times a year. And it will come for assurance that we are addressing our strategic objectives, that we recognise the risks that we have to those strategic objectives, and importantly for the board, that we have that the risk, the mitigations that we're putting in place are being effective. So thank you. That's a useful conversation. Right, we're now going to move on to Quality and Outcomes Committee.
Thank you very much. And this is the report from our meeting that we held on the 8th of April. And just to say, it's the last report I'll be giving as chair. It's been an absolute pleasure being a chair of the Quality and Outcomes Committee, and I'm delighted to hand over my chair to Julie, who I think will be an absolutely excellent chair of the committee. So just wanted to say thank you to Julie for taking that on. I am temporarily going to be chairing the commissioning committee, which is been really interesting setting that up, and particularly the opportunity there is to frame things as the ICB is now in its new role as strategic commissioner. And I will then be stepping out of that to take on my new role as chair of Merseycare. So just to really say thank you to everybody for all their inputs. So on the AAA report, I want to just pick up a few things, if I may. And the first of those were around alerts. And we have 2 alerts. And the first of those is around children and young people and our SEND update. And this is really really need to contextualise this alert in relation to the national SEND reform. And what you'll see as things stand today, that we do have some concerns around the increased demand for SEND services and the reduction in capacity that we have in the ICB, and you'll see there that we have mitigations in place to manage that in terms of mutual aid and also working with providers to deliver against the SEND specification. But this is really just a moment in time, because clearly as we work through the national SEND reform with our local response to that, then actually thinking about this in a very different way, I hope will enable us to have a more effective response to that very important cohort of children and young people who do have those needs. So that was really the first of the 2 alerts. And then the second alert was around our just concerns regarding the financial position of the Learning Disability and Autism Service due to the increase in the right to choose, and that's placing additional pressure on the budgets, both for children and young people, but also for adults. And I'm really pleased to report that through the commissioning committee, which is why I mentioned about the 2 hats in relation to this item, that we are having a report to our next meeting, which is around all the work that's going on to really think about, again, the response to this need and demand in a very different way, which is about looking at the whole pathway and thinking about how to manage people in a very different way that actually starts to look at how do you help people to be able to respond more effectively to people's needs, and to actually think about how we can use our resources more effectively to get better outcomes. So I think it's just really pleasing as I come to the end of my chairing of the Quality Committee to be able to see a change and a move forward on something that has been quite a tricky problem for a little while. You'll also note that we've got a couple of advices there. One is around the sustained improvements in the CHC timeliness elimination of long waits. And then we also have the work that is continuing around looking at our antimicrobial resistance and infection prevention control improvements in priority areas. And I think that's all I wanted to cover. Thank you very much, Chair.
Thank you. Thank you very much, Sheena. And yeah, thank you for your chairing of that committee over the past, 4 years. So, no. Any questions for Sheena? Yes. Chris.
Thank you, thank you, Jen. It's not really a question, it's just, I suppose, to reinforce the piece around the autism and the good work that's been done. And I think, is it resolved yet? No, but are we further ahead than we've ever been as a system in this space? And we absolutely are. And it's great to see the teams working so well together. So it gives real confidence to get a sizable movement in this space in this financial year. So yeah, just to thank you for all the support.
Thanks. Excellent. Thank you very much. Yeah, Kath.
Thank you, Chair. It's just a quick one. It's just around the membership of the Quality Outcomes Committee, because it previously has had local authority representation on it, and I think it's been quite a useful forum in terms of continuing healthcare and having those conversations. So I think there's been a decision not to have local authority membership on there, and I think I just wanted to raise that and where we have those conversations instead at a more strategic level in relation to continuing healthcare. Thank you.
I'll start and then I'll bring Aaron in. So I am hoping to have local authority representation in the form of public health, particularly. on those committees, because I think that's in line with what we're trying to do across this committee. I think there may be some alternative routes in as well, because I think particularly with some of the statutory functions, there's been a bit of some of the level of detail that's been taken to the Quality and Outcomes Committee is more appropriate to an executive forum. And I think that might be the answer to your question, but is that what you were?
Yes.
Yeah, fine. So I think that's probably where we're going to go. But rest assured, it's an active conversation. It's about getting the right level of conversation in the right place. Okay. I'm afraid I'm going to have to take the board back to the previous section because I failed to do the recommendations on the board assurance framework for the changing of the risks. So as well as discussing and assuring ourselves around mitigations, we do sometimes have to make decisions, and we're being asked to make a number of decisions around the changing of board assurance risks, which are, I am there, fine. So on BAF 1, which is fully developed vision, strategy, intentions and implementation plans for strategic commissioning, we're being asked to reduce the risk to its target risk score of 12, noting the work currently underway to review and refresh the strategic objectives and associated risks. Are we happy to do that? Yeah. For BAF 4, agreeing the agreed financial plan for 25-26, to reduce the risk to its target score of 10 and close, with a new risk assessment undertaken for 26-27. I think we probably keep that as a risk per se, rather than launching it every year in a sort of slightly bouncy way. But yeah, so I think we did meet our risk for the end of the last year. We have the new risk, but I don't think we'll give it a year, because I think when we really want to reduce that is when we are operating within our expenditure. BAF 5, develop and maintain effective partnership and collaborative arrangements and implement an effective governance structure for partnership working. We're being asked to reduce this risk to its target score 12, but to maintain oversight of this risk whilst strategic partnership arrangements are further developed. I'm seeing assent on that. Yeah. And finally, BAF 7, effectively implement an affordable all-age continuing care framework and deliver the enhanced controls established through the turnaround plan. We're being asked to extend the target risk to the 30th of June, which I think is a 3-month extension, to enable actions relating to the turnaround plan to be completed and for there to be consideration of any residual risk which may have reduced. And I think we can see that, given Margaret's intervention earlier, that is in progress. Okay, thank you very much. Apologies for that. So now we will continue to move forwards to the Integrated Performance Report. Craig.
Yes, thank you, Chair. So you have an extensive performance report and a quite detailed covering paper. I'm just going to bring out some of the highlights from a strategic perspective. So demand in the system continues to rise and slightly higher than demographic growth. So we've seen about 4% increase from GP practices, which is above our demographic growth. We've also seen increase in elective and A&E at just over 2.5% as well. So it's just to give a flavour of the demand that's being managed in the system. In relation to elective care, I'm pleased to say that we did achieve the 65% target by March 2026 for 18 weeks. The national focus has shifted very much to getting back to our RTT, which is referral to treatment measure. We have a plan to continue to see our improvement to meet the 92% target by March 2029. That's in our medium-term plan. It is agreed with our providers. We'll be monitoring that for impact and delivery. We have a small number of long waiters, just under 50, over 65 weeks, and we've got individual plans for all of those to give the board assurance. I know that's some detail, but it is one of the strategic objectives we are measured against. And we were slightly over our total waiting list, we were just over 238,000 and the plan was 240,000. So, sorry, 235,000. So, slightly over, but we are doing a significant amount of work to regain that position by the end of this year. In relation to UEC, I'm again pleased to say that we did meet the national target of 78%, and that's despite a very challenging last quarter. I was concerned we wouldn't meet it just due to the level of opal status that two of our providers were in for an extended period of time. So all credit to the providers, and by that I don't just mean our acutes, I mean our community and primary care providers who I think, and of course mental health, who did a sterling job during that period to continue to deliver performance despite some very challenging pressure. Children and young people, as we've heard, we've got specific targeted action plans to reduce the long number of waits in paediatric services. It does link to the SEND agenda, but there is specific action. That's one of the areas that I think could possibly be a board focus for the future in relation to a more detailed paper about paediatrics and children and young people. Diagnostic services did improve on the month, but didn't quite meet the Northwest position, but didn't achieve the national performance of 79.8%. We were at 81%. Again, it feels wrong to celebrate in one respect because we've still got 19% of diagnostics that aren't being achieved. So, but what I will say is there is a big variance. So we've got one of our hospitals at 98.3% and then one at 62.9%. So it's not everybody at that 80%. So we're trying to make sure that we target our intervention for those hospitals that need the most support, which I think is right to do so. Cancer standard, the 28-day standard was met. The 31-day standard was 0.6% just short of the target, so slightly narrowly missed out, but I think almost there. But we are still challenged, and it is a risk with our overall 62-day that the target is 85%, and we're stuck at 65% at the minute. So some way to go there on our 62-day, and there'll be a remedial action plan with the particular providers to look at dedicated interventions to improve that particular target. I'm pleased to say, though, I think this time last year I was reporting all 3 targets were being missed, so progress, but not quite enough at this moment in time. I've talked about urgent care. Mental health, again, has had quite a challenging period in relation to demand and pressure, but we only saw 3 out of area placements, and I think compared to where we've been when we were triple figures at one point, Chris, I think that is, whilst we don't want to see anybody in out of area bed, I do think that that's proportionate, and we have seen an improved performance against the reliable recovery target for IAP, but just not meeting the target just yet, 5% short, and the dementia prevalence target is being achieved, so which again is great news. There are a number of other elements within the report, and as I said, whilst we can take some comfort in our improvement journey, because I think we are improving in a number of areas, still slightly short of some of the targets, but and we want to make sure that we are not just resting on our laurels with regards to that performance, because there's still some way to go with particular areas. I'll pause there because there might be some specific questions either about the paper or the integrated performance report, but they're just the strategic highlights that I thought would be relevant to the board today.
Thank you. Thanks very much, Craig. Julie.
Thank you, Chair. Thank you, Craig. I'm really pleased that you made the comment about supporting the trusts, for example, where you've got the 60% achievement, because it was just to highlight that we need to also remain aware that that's just the tip of that iceberg, because that's in the areas of the highest deprivation and the lowest diagnosis. So we know that the prevalence of illness is much, much higher. And so for things like getting a heart scan to determine if you have heart failure will make a massive difference to the 51 years of quality life that Tracy referred to. So it's so good to hear that we're as an organisation going to really look at targeting where we send our resource. Thanks.
Good. Any other questions for Craig or comments on the performance report? No, thank you very much indeed. So now we'll move to the finance report. Steve Igo, as board members will be aware, is not here. And I think, Debbie, you weren't at the last Finance and Contracting Committee. So we're going to compress those two reports into one and do them through our Finance Director, Mark.
Thank you, Chair. Afternoon, everyone. So as described, I'll just quickly go through the report and then touch on the month 12 position that has previously been alluded to in early parts of the discussion. Apologies, everyone. I'm new to glasses and I'm really struggling to work out what to wear them or not. So
Welcome.
If you see me squinting, I'm really struggling today. So apologies. So the update report from the committee brings the board up to date with the last two meetings, one held in March and one in April. If colleagues will allow, I will skip over the numbers, the financial numbers quoted in those, because again, events have moved on and the values have now been superseded, which I'll touch on shortly. Regards to the other items of the committee business, a number of regular reports were received in accordance with its terms of reference. So in March in particular, standard agenda items regarding all age continuing care, some updates regarding the plan position and indeed risk management as touched on earlier on today's agenda. The committee also received an update on systems capital plans, financial grip and control and some of the green plan agenda, which again I thought were helpful discussions in terms of understanding where the organisation is at and indeed the actions that are required in each area. And April, we again received similar updates as part of our normal business, but again a more detailed discussion on the ICB's plan and the mitigations required for 26/7, which again the board has received previously. There were two more sort of substantive areas of discussion. So one on the annual assessments of our going concern and indeed the committee work plan for 26/7, and again all were really good and helpful discussions. So I'm sure that's what Steve would have said if he were here. So hopefully that does that justice. Just moving quickly on to the month 12 report, which is the next item on the agenda. Again, really pleased to say we landed the end of year position, both from an ICB and indeed at a system level that Aaron referred to at the start, and just quote a few quick numbers at you. So the figures are obviously subject still to audit, which is ongoing and expecting to be okay based on current conversations. But in terms of the key numbers, the system did deliver its required break-even position against its control total, which, if colleagues will recall, was a 164 million deficit and therefore was in receipt of an equivalent amount of deficit support funding to offset that. The individual positions within the system were a 9.7 million surplus in the ICB, which was required to offset the 9.7 million deficit in the provider trust. And again, there's some more information in the report on that basis. From a positive point of view, I'm just pleased to say that we did actually, as a system, improve on that 164, because in accordance with some of the national rules that were updated in Q4, we did actually receive as a system some extra additional deficit support funding around £11.5 million. So we actually came in underneath that 164, and again that was recognition again of the system and the work that again Aaron referred to earlier. So again, subject to audit, but a really good position compared to where I think we were at certainly at the start of the year, and certainly when I joined in September. There were lots of risks and issues that needed managing. So again, credit to everyone across the system for pulling together in the way that they did, and really on to 26/7 as part of that process. More detail in the report on the individual positions, but again, aware that we will be talking to this as part of the session in June as part of signing off the accounts and audit. So if we can touch on that, then that would be helpful. Hope that's okay, Chair. Thank you.
Thank you very much, Mark. I do think it's worth just pausing there, because that was a significant achievement for the system, and not just in financial terms, in terms of proving that we can pull together as a system and that we can deliver what we said we were going to deliver. So I banged on a lot about that at the beginning of the financial year. Thank you for steering us through since September, and I think your impact has been enormous, Mark, over that period. But well done. Good. Any questions? Yes.
Again, I think it's just to reiterate, I think the system working's been really good in that space, and Mark, just to call you out again in that space. But I think it is an amazing achievement, but it's been done also at the same time as not impacting on quality. And I can speak from a mental health perspective that we've seen demonstrable reductions in patient and colleague harm at a period of this time. So I think that it's a good test base to say you can pull out recurrent savings and improve quality. I think we do have to note the impact that has on numbers of management changes and culture, and we've seen that in the staff survey results for, and that, you know, ICB is not immune to that. So it's noting that, but I think it's a really good from a financial and a quality perspective to end where we've ended 25-26.
It's just a related point following on Chris's comment. I was going to pick it up actually when Jane gave the update from the Culture and People Committee. It's really important that we've committed to re-engage and rerun the staff survey.
Yeah.
It's very easy and actually logical to draw a conclusion around management of change, complex transformation and poor satisfaction, because we've said it's really exposing, it's worrying colleagues, you know, asking if it's a great place to work when you're not sure if you've got a role in the future is a pretty crass question to ask, but that's the survey and that's the response we get. But actually we need a benchmark, and then we need to start to measure where we need to start to take some action. And even now I'm getting feedback from colleagues going through transformational change that the way it's being managed is likely to lead to more positive responses about feeling connected and engaged with. Might not have a positive outcome on place to work, but the way that colleagues feel going through the process is important. So I just wanted to make the point that supporting continuation with the National Staff Survey, I think, is going to be an important reference point for us each year as we move into the new operating model, Chair.
Yeah, absolutely. Good. Okay, I'm going to propose that we take a short break. Everyone looks so relieved when I am prompted to remember that. So I think it's now it's nearly past. Back here at 22 prompt. Thank you.
footprint from 8 acute sites to 4, so consolidation. That's not to say people will miss out because there's a consolidation approach. We would still have satellite clinics in some of our more coastal areas, so Furness and Blackpool. When we look to consolidate activity into hubs, this has a whole range of benefits, so including enabling a more effective skilled workforce, maximises the available capacity, economies of scale, reduces service disruption, and also will strengthen our clinical collaboration. We recognise this will potentially have an impact on staff, and that's included in the case for change. And we've obviously need to ensure that we assess the travel implications as well. We also need to think about travel cost support schemes and our non-emergency transport, which features. The staff impacts will be managed through our early engagement, which again is a proposal in the case for change. And we will be monitoring this with the national metrics that are outlined. We've already done some extensive engagement to date, 2,000 responses from our public, 870 plus specific orthodontic responses as well, and it demonstrates broad support for the direction of travel. There's updated financial modelling currently being undertaken to make sure that, you know, we've got value for money, and that would also, if we could proceed today, would feature as a strong element of our pre-consultation business case. So recommendation is to endorse the case for change, enable the programme to proceed in line with our agreed clinical service change process that I've outlined previously to board. Thank you, Chair.
Thank you, Craig. Any questions for Craig on this? Yes, Sheena.
To say, and you'll see that when we come to the AAA report later on in the meeting, that this did go to our commissioning committee, and we also endorsed it to come here for consideration. Thank you.
Excellent. That's really good. That's great that we have that scrutiny now before it comes to board. So thank you, Sheena. Jane.
I'll try not to draw too much of my own personal experience here, but actually it is interesting when you've had this experience. And, you know, I was on a very, very long waiting list for secondary care orthodontics, so I know how that feels. There's a lot that I think is really sensible about this proposal to improve the situation. And in terms of staffing, I think altering the skill mix will be helpful. But secondary care orthodontics does need specialist consultants. And I was reading in this that one of the key problems is a lack of consultants or our inability to recruit them. And I'm guessing, although you can correct me if I'm wrong, that in part that's to do with people working in the private sector rather than in the NHS. And I wonder whether we can put all this in place, but whether that will be an ongoing problem that will still limit the number of consultants that we have.
I mean, it is a potential risk. I think part of the problem is the fragmentation of the service and it being attractive and appealing to go and work when it's spread so thinly, not having the right resilience. So the model is intended, as I said, to consolidate, to have that hub and satellite model, and therefore being a more attractive place to work. And I think hopefully that will see us be able to retain our consultants more, but also recruit new consultants. There is always a risk when it's a very specific speciality like orthodontics, secretary care. But even when we've reached out to the private sector to support with mutual aid, it's been slim picking. So I think we need to make sure that we do a targeted sort of recruitment based on a new model, which actually is a lot of the feedback we got when we did the engagement.
Thank you.
Thank you. Aaron?
Yeah, thank you. And it's good with the committee oversight pre-board. It helps, I think, give it the time and scrutiny that's needed before a board decision is taken to support. I just wanted to recognise the increasing maturity of the provider collaborative across our region, in that if I go back 4 or 5 years, it would have been very difficult to get a collective view of this kind of model across the providers they currently stand. So I'm keen to explore at greater pace and scale what we can do with the collaborative around the improvements we know we need to make in other fragile services. So it's in our transition kind of purview, and it's in the addendum to my report around service change. But we are awaiting a proposal from the collaborative around acute and specialist configuration proposals designed to strengthen these kinds of areas. So I'm looking forward to receiving that. I think then there's a challenge for us as an organisation to receive it in a way that then facilitates commissioning intentions and the pace that we need to then close these gaps, because we were talking earlier today, it can be quite a time between an issue raised, a decision made, and then change enacted. So we need to do some thinking between us and other partners about how we do that. But it's a very good signal for me around the maturing relationships in the provider collaborative.
Excellent. Thank you. So, yeah, sorry, Debbie.
Thanks, Chair. So we did have the benefit of looking at the case and sort of offering the scrutiny before. So I'm not going to go through because we've summarised it. The one question that I got remaining was just to clarify in terms of the next stage, Craig, if we'll be clarifying if there's any estate need or sort of capital investment that's needed. Because at one point in this report, it updates that the current physical estate available doesn't have the space to accommodate the future operating model. So you don't need to give me the answer now. It's just really a question in terms of if it does move forward, will that be included and spec'd out for us just so we've got a full awareness of costs?
That's part of the financial modelling that I described in relation to estates, which actually forms a part of the pre-consultation business case.
Good. Happy to progress this on to the next stage. Good. Thank you very much indeed. Okay, so now we have Commissioning Committee Escalation and Assurance Report. Sheena,
Yes.
first one.
Yes, first one. So, as we said, this is the inaugural report back from the Commissioning Committee, which was from the 22nd of April. And what I'd like to do is to just take you through the AAA report. But just to say before I do that, we were very mindful in setting up the Commissioning Committee that what we need to do is to actually spend some time together to get to know each other so that we can understand how we are as effective in working as we can do. So some time will be set aside to do that. You'll also see in the escalation report that, or the AAA report, that we are actually under the terms of reference and business plan going to come back round those in 3 months' time, because clearly as we start to establish as a strategic commissioner, we'll kind of learn as we go along, and it may well be that the way that we've set this up to start off with in terms of both the terms of reference, probably not so much the terms of reference, but more about the actual business plan for the year, that may alter and change. So we just wanted to kind of just say that we've got ourselves up and running, but I think, like anything, there's continuous improvement and learning to make sure that we can be as effective as we possibly can. So I think the other reason for saying that is it'd be really helpful to get feedback from the board, if we can, Chair, about, is this useful? Is the things that you'd like us to do more of or less of? And I think, that'll be a good learning as well. And also, as I said, it's the wider system too. So how are we going to fit in with, as we already said, around the work that the provider collaborative is doing? So I think it's just important to think about in that way. So in terms of the AAA itself, we didn't have any items this time around to alert. We did have some areas of advice where we've looked at our commissioning for success. We considered 8 clinical policies around the committee about no material change of clinical policies, and we approved those policies of ratification. And then we had, on behalf of the board, which was something that the board had asked us to do, was to really have a bit of a deep dive into the local enhanced services, and in particular looking at last year and going forward its effectiveness, which is something that we're going to be keeping under review. There is actually a really helpful pictorial, which I think might be useful to share with board members, that actually sets out so people can see, well, what was the activity that was undertaken, and starts to get a sense about the way that will have an impact going forward in terms of changing the way that need is met. We then also, as you can see, had some items for assurance. I've already mentioned about the business plan and the terms of reference. That really important bit about the committee getting the assurance about working with people and communities, and the report back on the tremendous work that's being undertaken to actually understand insight that's being used to inform decision making, and that influencing network of over 2,300 people. So I think that's going to be really important as we go forward again, just to get that assurance about insights in terms of the decisions that we're going to be making as strategic commissioners. And then, as we've already said, the case for change was considered for secondary care orthodontics that we've just looked at as a board now. So that's all I really wanted to say. Thank you, Chair.
Thank you very much, Sheena. Any questions for Sheena? No? Excellent. Sounds good. And look forward to future reports from the Commissioning Committee. Okay, so we now move on to the Audit Committee. And again, board members will have noticed that Steve Spill has given his apologies. So once again, we're going to turn to Mark. Just to say that Steve did give a verbal update on this. So this is just the written version of what he told us at the last public board meeting.
Thank you, Chair. Yeah, very quickly, I'll just repeat Steve's earlier point. So this was the meeting that was held in March. Again, really critical period for us in terms of audit activity that colleagues again will know about. And just to bring to your attention from the AAA report, two particular items, and then happy to take any questions on any of the remaining points. The committee received updates on the internal audit progress report and the new finance ledger, which I'll briefly speak to. Regards to the internal audit report, there were two limited assurance reports in respect of areas of finance and business and IT continuity plans. Both areas have obviously been subject to lots of conversation in regards to the risk ratings in accordance in each of those different areas, and both now have well-developed action plans and with recommendations that are being tracked for delivery in Q1 as part of the ongoing process with internal audit. With regards to the ledger, whilst the operational challenges have settled down, there are lots of ongoing challenges that the team, not just here but across the country, I know are continuing to have to try and deal with, and we're looking to try and find ways to optimise our use of the ledger in the best possible way. But I think it is fair to say it's less efficient than the previous version, which we continue to try and work our way through. We are working with external audit. I suppose just to flag to the board again, over the coming weeks, you will hear and see some of the external audit perspective on that. It does look like we are going to incur additional costs as a result of the change in ISFE 1 to 2, as a result of some extra testing that the team are going to have to do, and that's notwithstanding the extra work that's been done nationally to try and assure audit colleagues on the process and some of the service auditor reports that we'll no doubt see. So again, you'll see that in the coming weeks, but that was the second area to alert to the board. So a number of other items in the committee, but happy to take any questions, Chair. Thank you.
Thanks very much, Mark, and thanks for doing that. Any questions for Mark? No, excellent. Okay, so now we have this North West Specialised Joint Committee. Craig.
Thank you, Chair. This is slightly out of date as we've already had a further North West Specialised Commissioning Committee, but due to the timing of our board, it's not possible to produce the report in time. There are some alerts, advice and assurance. The issues in relation to providers aren't like South Cumbria ones, but it's important just to note because they obviously do impact. So neonatal incidents at MFT and renal dialysis. In relation to the GM system, there were further updates and progress has been made, so you'll see that at the next report. One that relates to us all, though, is the ICB workforce pressures, and I think we've had previous updates at the board with regards to where there is potential gaps in teams and our business continuity. I have obviously updated on our Office of Pan ICB commissioning to the board, so that's an advisory one, and the AAA reporting. There was further advice regarding our health inequalities strategy as well, which will feature through our governance, and then assurance on quality oversight, finance and planning, which is routine. There's nothing untoward, and if there was, they would go it through to our appropriate committees for assurance. So happy to take any comments or questions, Chair.
Thank you. Thanks, Craig. Any questions for Craig? Comments? No. Okay. Transition and Change Committee. So this is the terms of reference for the new committee, isn't it, Deb? Thank you.
Thank you, Chair. Yes, so the board, as Jane referred to earlier, previously agreed in March to review the People and Culture Committee and Transition Committee with the intention of bringing these together into a single committee aligned to the Model RCB blueprint. So this paper proposes to establish a new time-limited Transition and Change Committee from the 1st of June to provide that focused oversight and assurance through this transitional period. The committee will also ensure that appropriate governance of people-related functions are maintained during this period, and that give that clear line of sight for the board through assurance and escalation reporting. Finally, the terms of reference will be reviewed after 6 months to ensure that they remain fit for purpose as we get any further clarity on regional model blueprints. And yes, the terms of reference are attached in full for approval.
Thank you very much, Deb, and thank you for all your work on this, because there's, as I say, there's quite a lot been involved in all of this. Are we? First of all, are there any questions for Deb? No, in which case, are we happy to approve those terms of reference? Excellent, good. And finally, report concerning matters considered in private. Still with you, Deb.
Thank you. I'll take the report as read. The board has met 3 times, one being an extraordinary meeting on the 16th of March, and that was in relation to medium-term plan, final plan submission. So that was aligned to national and regional timescales, and then 2 further meetings which have been a focus on much of what we've talked about today, and particularly the BAF, Model RCB blueprint, and 25-26 outturn and financial position. Thank you.
Thank you. Okay, does anybody have any other business? No, I don't think we've identified any items for the risk register, particularly over and above what we've got. Okay, so in which case I'd like to thank everybody for some good discussions, and for those watching, and formally close this board meeting. Excellent.